time, we'll move on. So this is the last talk of the session, and then if there is any time, we will have a discussion on Dr. Tinku's talk also, which was also on PDR. Um, so most important, I feel that we should know is when to operate and whether even to operate. So if we see patients like these, which are relatively stable, vision is good, there's nothing to be achieved by immediately operating, just doing good laser, and these patients more than 10 years old with stable retinas. Similarly, this patient is not even aware of any problem, 6 by 6 vision, advanced PDR, so just laser and no surgery. Despite the macular traction, there's no indication for surgery. More complex cases like this, only the macula is attached. I think the vision is good, 618. So it might be good to wait and watch rather than operate and then give them zero vision at the end. So we just observed this patient, and in a few days, there was a detachment at the macula, and that is when I intervened. And we tried to initially just minimize the surgery by doing traction relief and left it at that. And many times this works. The macula remains attached and we can just do laser. However, in this patient, it did not, the macula did detach subsequently. So under oil itself, as was in one of the other talks now, it's good to remove the membranes while leaving the oil inside, because oil keeps the macula, the retina flat, instead of allowing a bullous kind of detachment. So membrane peeling is safer. And also it does not allow bleeding to disperse. So our view remains clear. And once we have done a significant amount of membrane removal, then oil can be removed to allow vitrectomy to go in. But at least most of the membrane peeling, as far as possible, is best done under oil. Now, once we've decided that we have to operate, even then as much laser as possible should be done. And not only before surgery, but also during surgery, as much as laser as possible, and post-operatively as well. Preoperative anti-VEGF is very important to give a good view, but there is a single most important disadvantage, and that is we cannot see the breaks during surgery because they don't bleed. So earlier we used to have, without anti-VEGF, this type of picture where we are not able to see because of bleeding. But now, though there is no bleeding, the other problem is if you see there is a break here, but it doesn't bleed. Similarly, there's a second break here, but it has not bled. Again, a third break. So we have to be very careful we don't miss these breaks. We identify the breaks and keep diathermizing them because they won't be seen later on. There is no bleeding. So that's a major disadvantage of anti-VEGF use, preoperative anti-VEGF. And when there is some space between the retina and the tissue, it's good to just go with a vitrector in the cleavage plane, the vitrector facing anteriorly, so that the retina is not caught. But where there is no space between the retina and the tissue, there the vitrector faces posteriorly to be able to shave the tissue off. And it's not necessary to remove all bit of tissue, fibrous tissue. It's okay to release the traction and leave areas which are relaxed and then attach the retina. And most of the time this works. Now sometimes when we try to do a blunt dissection going between the retina and the tissue, you can have these kind of major breaks. So this kind of blunt dissection has to be avoided if the retina is very thin around the area of the glial tissue, and if the adhesion is very strong. There you have to go with sharp dissections. So here you can see the two breaks caused by lifting the retina. So if the retina is thin or the adhesion is strong, then blunt dissection doesn't work. Sometimes we have this kind of bleeding, especially if anti-VEGF has not been used preoperatively, and you have some breaks which we cannot laser because of poor visibility or the blood. There we have started using fibrin glue. The two components are instilled sequentially over each break so that the breaks are closed and you get a good result. Similarly, if the break is very close to the center, as here, then you can just put glue over the break, this break, and you can see that the retina hole is closed by the glue and retina is attached. ILM peeling wherever possible should be done, even in PDR, because it gives a very good post-operative view, as you see in this OCT picture. The post-operative foveal restoration is fast. The visual quality is much better. Only problem is that the ILM peeling in PDR is more challenging. The ILM I have found is to be much more adherent to the retina. So it takes much more time, and it may be just piecemeal. It may not be a complete ILM peel. But it's important not to go very aggressively over the center and create a macular hole, because that would be a different problem then. This is how ILM peeling helps. Within a week or two, you get a very beautiful contour, and the visual quality is definitely much better with ILM peeling. Now, during surgery, if we have bleeding, you should not allow it to clot. Use the reflux from the vitrector to raise the blood and aspirate. So keep on using these alternately, the reflux and aspiration, so that the blood is not allowed to clot over the surface. And you can still get good result. This is in earlier days when we were not using anti-VEGF. If there is a clot, leave it with oil, face down position, the retina remains attached, and then you can go and remove the oil after 2 weeks. As you saw, it came out very easily because by now it has clotted. So there is no rebleeding. And again, under oil, we can do resurgery. And if there is bleeding, it can be removed easily because the blood is heavier than oil. It settles at the most dependent part, and it can be easily aspirated. Sorry. All right. And the last part is that most of the time we focus on the posterior vitreous, but a thin sheet of anterior vitreous is left behind, which holds the blood. And if you find most of these cases, you just remove anterior blood and the posterior vitreous was already clear. So you have to make a special attempt to remove the anterior vitreous first before we go to the posterior vitrectomy. Also in PDR cases, I prefer to leave oil because it gives us a good view to continue the even if tamponade is not required, or gas might work. Because gas does not allow a good view for pan-retinal laser post-operatively, and also the visual rehabilitation is very good with oil from day one. Even if there is bleeding post-op, it remains limited to the lower quadrants when oil is in place. So the media is clear, it allows us to examine and laser, and patient's vision remains good. It does not allow the blood to disperse. Persistent SRF is common and should not be a reason to reoperate. You can just monitor it serially, and you can see that the SRF is reducing over time and resolves. Unless there is an open break and there is no laser around that area. So thank you very much. I think now we can have a couple of minutes of discussion with Dr. Tinku's talk and mine. Anything from the panel or from the audience?
Dr. Mallika, you very well highlighted the point that peripheral membranes, I mean, we don't have to be too aggressive and remove all the membranes. Some peripheral membranes, if they're small and if they're very tightly adherent, can be left behind. Rather than risk creating a nitrogenic break, it's better to leave those small membranes behind.
I think every membrane or tissue, we have to see how much it's contributing to the detachment, and whether it will continue to contribute. If it will not, then I think it's best left.
So then we can leave that alone.
One of the things is, as you mentioned, the bottle height. I think you had mentioned in your talk. So if you're not careful, sometimes you see there are central retinal artery pulsations. So look for those, especially in diabetic eyes, they're already ischemic. So I found that sometimes these eyes become very pale, the disc becomes very pale post-op. So very important to see that the perfusion is maintained during surgery, and also during fluid air exchange, etc. We don't traumatize the disc too much by repeated touching over the disc, because there can be a lot of trauma to the disc, ischemic or mechanical, where we are focused totally on the retina, but visual outcome can be poor.
Also, in a case of TRD, do you attempt to drain the fluid? You showed the last OCTs that the fluid does come down over a period of time. Do you ever attempt to create a retinotomy and drain it?
Only if the fluid is increasing over time, then you know that there is a break somewhere. So only if fluid is increasing with time, but if it is the stable or reducing with time, it doesn't need removal.
No,
Miss,
on
if you are,
table,
yeah.
on table I've done.
No, but if you are sure that you do not have a break, it's
Yeah.
just a
So you
traction,
can just
these
leave
eyes
it.
will be lifted because of the fact that there was a traction. But now that you have removed the traction, there is no break, you can just leave it because over a period of time it will flatten down.
Yeah,
But
so
creating a new
that's what
break,
I wanted to
yeah.
highlight. There's no need to drain that tractional fluid. It will come down on its own over a period of time.
Also like to
Anything from
highlight
the,
two articles for, I think, everybody in general. I think from a lot of the surgeons who are here and even otherwise prolific surgeons from the country. 2 years ago, we got like a Delphi statement out on like a semi-consensus from surgeons on surgery for proliferative diabetic retinopathy, in which some of these questions were tackled, and there was a level of evidence which was given. So this is an IGO and goes by the name of a Delphi, approach with outcomes of surgery for proliferative diabetic retinopathy. I would strongly suggest, go through that. Lots of experienced surgeons of the country contributed in that, and also recently a review article on MIVS in proliferative diabetic retinopathy in IGO a couple of months back came out, spearheaded by the AIMS group. And I would strongly urge people to go through that. I think a lot of what was discussed regarding diabetic retinopathy, especially PDR surgery, has been collated very well in those articles.
yes. Take the mic, can you? Here.
Patients are not systemically optimized.
Can you speak into the mic?
Sometimes our patients are not systemically optimized to be operated as soon as possible. So we have to wait for 3 to 4 weeks. And can we do lasers of the unlasered areas in macular TRDs also before surgeries?
Absolutely.
Yes.
Even if the patient, I would say, is optimized for surgery, I would suggest that if you can pump in laser at that time, you should. Also, mind you, if you have someone who let's say does not have a TRD, is let's say a patient who has very severe, let's say a premacular bleed, and you feel कि ये तो relatively easy case होगा, unlasered, but has CKD, and you take this patient, you get fitness, you take this patient up for surgery, the patient is not lasered, and you pump in a lot of laser at the end of surgery because typically no membranes to be removed, surgery went off fine. So what you do pre-op when you do, PRP is you do it over sessions. Here you're pumping in a lot of laser at the same time, and especially in CKD patients who have fluid overload and who might not be able to, have their regular twice or thrice weekly set, dialysis because of surgery on a particular day. They can land up in first or second post-op day or third post-op day with huge amount of exudative retinal detachment to the point that people think that it's reg RD, but it's not. With a lot of fibrinous reaction, and that's all laser-induced, and what you have done. So please, if there's an opportunity and the media is permitting, pump in as much laser as you can beforehand.
And second question, in many conferences, they prefer gases over oil. In our
Can you
practice
speak
also,
into the mic? I don't think it's audible.
in many of the conferences, many surgeons prefer gases over oil in modern surgeries. But in our institute too, we go for oil. What would be a threshold to select oil over gases, or should we keep the threshold low in PDR cases?
Dr. Shanmugam, you want to speak?
There is no threshold to say that what it is. So if you have removed all the membranes adequately and there's just a superior break, then you can leave it with air also is adequate. Not necessarily all the time it has to be a gas. But a complicated case with inferior breaks, and of course the ideal situation is you remove all the membranes in diabetic patients. You leave behind anything, oil is not a substitute. So ultimately the breaks will lift up. So you need to remove all the membranes. And if it's a one-eyed patient, which is often the case in diabetic patient, then again you will use oil. So there is no, so if you go to the West, people will keep saying use gas, but the type of cases they manage is different from what we manage. So more often we would be using oil, but depending on how simple or difficult the case is, the threshold will vary.
Thank you, sir. Thank you.